Good evening, all. Good evening. Welcome to tonight's Health and Adult Social Care Policy Accountability Committee. My name is Councillor Natalia Perez. I'm the chair of this committee. And before we start, I have a few housekeeping points. This meeting is being live streamed to the Council's YouTube channel. By participating, we are consenting to being recorded. Please can officers and guests introduce themselves when they first address the committee. If the fire alarm sounds, please leave the meeting in an orderly fashion by the staff fire exit, which is behind me to my right. Officers will direct you to the assembly point in Riverside Gardens. Let's move on to agenda item number 1. Have we got any apologies for absence?
Apologies from Councillor Rosenberg.
Thank you very much.
And apologies for lateness from Councillor Noire. She's on her way.
Thank you very much. Agenda item number 2. Do we have any declarations of interest? No? Thank you. Agenda item number 3. Do members agree the minutes of the meeting held on the 27th of March, 2024 as an accurate record? Agree? Great. Okay, thank you. Let's move on to agenda item number 4, Hammersmith and Fulham Health and Care Partnership Update. So I believe we have with us Caroline Farrar with this evening. Good evening, Caroline.
Good evening, Councillor Perez and everyone. So yes, I'm Caroline Farrar. I joined in July as the Managing Director for the Hammersmith and Fulham Place Partnership. It's a new role, although some people have done it as part of another role. It's the first time that the borough's had a dedicated place Managing Director role. And that's important because it's across the NHS providers, the council and the Integrated Care Board. So I describe it as a three-legged stool of a role. I don't have a team and my responsibility is bringing people together for the benefit for their health and better health and wellbeing outcomes of the population and communities of Hammersmith and Fulham. So yeah, very pleased to be here. Do you want me to give you a short introduction?
Yes, first of all, welcome to tonight, and thank you very much for that introduction. Absolutely, yes, we've seen the report from the agenda papers, but yes, please go ahead.
Yeah, so being new to the borough, I was really keen to get to know it a little and spent a lot of the summer walking the streets, visiting services and frontline staff and talking to lots and lots of people about the key issues. And what some of the senior strategic stakeholders said to me was that there was a need to refresh the partnership and to develop better, more productive working relationships between the different parties, the many bodies that serve residents in this area. And there are a lot of organisations serving the bodies. So as well as the council, I'm sure you're very familiar with the health provider landscape, but I think in my experience, it's quite a fragmented landscape, and that does make it difficult, I think, for perhaps council to interact with and for residents to experience sometimes some disjointed and fragmented pathways. So it really is the ambition of the partnership to try and make that work more effectively for residents. And then understanding the needs of the population is obviously a key first task as well. The Integrated Care Board has recently published its shared needs assessment, which I think contains some really interesting facts and figures about Hammersmith and Fulham, including, I was really surprised to see the lowest 3-year life expectancy at birth in North West London, which clearly is an issue that we need to work out what underlies that and how we're going to respond to it. I've spent quite a bit of time up in White City and Wormholt, which I think you're the ward member for. I can't remember who was the ward member, but yes, and and recognising that being not the only, but certainly the largest area of deprivation in the borough, and with all that tends to go with that, and spent time up there talking to clinicians and residents. So what we've been doing is conducting a review of how the partnership is operating, including its work streams and governance. We know we've got more to do on developing a collective sense of purpose and ambition, and we are refreshing our work streams and governance. We anticipate taking the final version of what we're proposing to the Health and Wellbeing Board in December, which is in about 3-4 weeks' time, isn't it? Yeah. So we've given you our refreshed partnership structure, and look forward to telling you more at a future meeting when we've got a bit further. Thanks.
Thank you very much for the updates. Appreciate it. And yes, definitely, we look forward to hearing more about the developments. So I want to open it to committee. Yes, Councillor Lloyd-Harris.
Thank you very much. Thank you for your report. Actually, it was quite interesting. I've got a couple of questions. The report is quite heavy on the north of the borough, and we talk about Wormholt and White City as being areas of greatest deprivation. Now, I've always had a bit of an issue with this because most of the reports we get are directed to the north of the borough, as though central and the south do not have significant issues, but it doesn't generally feature in reports. Yet where also the council is putting in a lot of money, a lot of resources into the north, but from the stats here, it's not actually producing the sort of outcome I would hope, which is reducing the issues that we have up there. So a lot of them are things that we have some control over. So why is this happening? What can we do better? Because it isn't just the north, because the money clearly is not making a significant difference at the moment. So is there an alternative plan available?
Can I clarify? Are you asking me two questions? One, there are factors in the centre and the south as well, and then how do we address deprivation and inequality? So I think I absolutely agree with you. There are issues across the borough. I was very selective in the data that I brought here because obviously our great public health team publish already a joint strategic needs assessment, and what I wasn't trying to do was to replicate the whole of that in my fairly short. What I was trying to do was give you some headlines of recently published data. But I think we absolutely do agree that there are some issues that we need to tackle across the borough, and that's what we are developing now in terms of our work streams and governance. And there will be work streams in every part of the borough. It won't just be the north. I think obviously the question about addressing inequalities is a much tougher challenge. You know, I think the Michael Marmot report, the Fair Society, Healthy Lives, and then the follow-up report just published pre-pandemic talks a lot about the wider determinants. And we know that some of those wider determinants have gone backwards rather than forwards in recent years. So I guess health and local authority services can do as much as they can to set that context and support residents. But ultimately, we need that concerted effort on economy, on good and healthy places to work, good child development. And I know that we are all keen to work in partnership on those areas as well, and that will form part of our plan.
Thank you very much. I think Dr. Lang wants to come in.
Thanks. Councillor Lloyd-Harris is absolutely right. So the Lily ward and the Clem Attlee estate is in England's 10% most deprived wards. We've just secured really generous NHS funding for 1.5 community health workers. They're called Chewies. We're copying the Westminster Pimlico Churchill Gardens model. So we're very happy that we secured some NHS funding for that. As Caroline is absolutely right, and it's in the health and wellbeing strategy, we do focus a lot on housing. housing PAC was really successful last night. Good and decent homes, jobs. So not just in the north of the borough, we do a lot of work with DWP as well. Jobs, everything that you've said, Councillor Lloyd Harris, opportunities, environment, green spaces, all of that. But we don't forget the south. Councillor Nwagbe is also here. There are certainly large council estates there, so we do a lot.
Thank you very much, Dr. Lang, as well for that information in terms of the work and the focus work that's happening in the south part of the borough. It's good, thank you. Jim, go ahead, please.
Thanks. I think that, thanks, Caroline, for the report. I'm a very long-term resident of the borough, and I've worked here in education for decades, and I still learned a variety of things I didn't want to know from this, and that's good learning, which means good teaching. But I would echo what Councillor Lloyd Harris said. I think a deprivation map of the borough would actually be very useful, because I know from walking around the borough day by day over decades and working with youngsters here that there's a great deal of deprivation. It's very hard to tackle because the country's got, in my view, something very unenvious. We're now the second most unequal country in the developed world, and we've been going in that direction for some time. Turning that around is beyond any one council or any one health system, but a recognition of where poverty deprivation is helps work on that. And I was taken by something on page 15. Conversations are continuing to agree priorities and work streams, taking account into feedback from frontline staff and residents. Now, I think that's quite important. So I'm wondering how widespread feedback will be, particularly from residents, because I know NHS staff have interesting conversations day by day with each other, but far fewer conversations between full-time NHS staff and actual listening to residents. Without listening a great deal, nothing much will change, despite an enormous amount of hard work. So I'm wondering about the structuring of the conversations to bring insights from residents into what's being planned. And I think there's a second point comes up, as those of us who go to ICB meetings will notice, sometimes residents, their priorities may come into tension and sometimes in direct conflict with what the ICB from Marlborough Road says. So there is actually something there about adjudicating differences so that residents know they're not just being box ticked, but their insights will actually change things. And there's not much evidence that's been happening in recent years. So there are two questions about deprivation there, and how do you listen to people, and how do you make voices heard as against decision makers in Marlborough Road?
Yes, thank you, Jim. I mean, I absolutely recognise that, and the report does talk about the pockets of deprivation across the borough. And when you look at the map, you can see them very clearly, and they are spread across, absolutely right, across the borough. We do have those maps, and I'm sure we can send out a map. Then, in terms of resident insight, I guess it feels like a real priority to me to get some work moving. And what I'm really keen to do is to build on the insights that are gathered in lots of different places already, in things like the ICB's patient reference group, but also there's the building trust work, there's lots of other engagement and insight gathering work that we are able to draw on. And the way that I think we want to construct the work streams is that each will need to develop some clarity about how it's going to conduct the co-production element of that work stream. So how it will have that conversation to make sure that we're gathering the right perspectives. So and that needs to be across across a wide range of people and groups. So I guess that's part of the next stage, really, to identify exactly how we plan to do that. I haven't brought, obviously, because I won't be bringing the plan until we go to Health and Wellbeing Board, and even then it will be an outline plan. It's not that what we're doing is determining everything. We're determining broad areas of work rather than a detailed line-by-line action plan. Yeah.
Thank you very much for the headlines. Are there further questions or comments?
Sorry. Yeah, there was just one that we sort of discussed together. I mean, why the rates were so high for self-harm, mental health, suicides, STIs in the borough, and which demographic, because again, it's not sort of set out there. And the other thing I wanted to ask was, the report states that these statistics have worsened over the past 3 years. And is that from the 2020 date when you started the report?
Can I just clarify which you're asking me about? So the STIs point being on, is that in the life course? Is that in the life course diagram?
Or is it?
I think it's, no, it's the one with all of them. So it's
Page 18, page 19 on the report, where there's very
The very-
little graphics are.
Yeah. Yeah. So that's the public health life course. Do you want to take that
Dr.
one?
Lang.
Yeah, thanks. Sexually transmitted infections have rocketed in all of London, so we're no different from the rest of London. That's
Okay.
a cold comfort, but we do a lot with our sexual health clinic. We commission Chelsea and Westminster Hospital. Their clinic is at 10 HB Dean Street, and also the centre at the Chelsea and Westminster Hospital. Sexual health services are under pressure, but yeah, we're not different in that point of view.
Are you going into schools, educating young people?
Yes, we have schools teams. We have a resilience team. If that worked, we would do more of it. So it's different communities. It's not in children and young people. It's different specific groups. I'd rather not go through it just
Okay.
because they're
No,
quite
it's just that I think
stigmatized. Yeah,
Those kind of demographics aren't clear on
yeah.
that chart.
That's fine. And also high suicide rates. Happy to bring that back. I think we have bringing back an update. Our factors of risk factors for suicides in the borough are high in terms of crime levels, housing, unemployment, and substance misuse. We also have the highest drug-related deaths in London. So we are a borough of extremes and extreme need. We're addressing all of that in very, robust public health measures, but I don't deny the need. We worry about it. We work on it every day. But yeah, sexual health has to be put in the context of a post-COVID situation in which, in particular, gonorrhea, syphilis, and other diseases have gone up.
Thank you, Dr. Lang. Caroline, please.
Did you want me to take the question about life expectancy, which I think was also part of the question? Well, I think it has it as it says in the document, it has dipped everywhere, and that's part of the pandemic effect. But it's the comparative position that we were interested in particularly.
Yes, Councillor Harris.
Thank you. I think this is actually something we discussed prior to the meeting, that back on this page with all of these very attractive little symbols and everything else, we get your drug deaths, suicides, violent offences and everything else. Whilst that's useful having that, and I think this is where we're maybe a little let down by the report, is it sort of stops giving you this picture, which is in some areas is absolutely horrific. It is really disturbing. Yet it doesn't tell us what potentially we're going to do. It would be so much more useful if we said, okay, suicide rates are 11%, London's 6.9. Why is that? What measures potentially are we looking at in order to reduce that? I'm only just saying that one, violent offences, I mean, that is a serious problem. So we have some really positives in this, but we have some absolutely horrendous figures. But there's nothing to say, what are we going to do about it? It stops short of that. And I think this would be a better report and more beneficial if we actually had the next stage or part of the next stage?
Carolyn.
Yeah, so my understanding, this is a scrutiny committee, so the plan will go to the Health and Wellbeing Board first before it comes here. I think what we couldn't do is to try and address every single issue. We'll be seeking to improve the overall conditions and the overall outcomes through some of that wider determinants and prevention work that I talked about. But actually, you know, we won't have a plan that says we're going to do this about this and this about this and this about this. It's not possible for us to work in that way. It will be, we will need to prioritise certain areas to get work underway, and then the partnership and the work will develop from there.
I understand that, but you could give us a sense of what may be considered. I'm not asking you to produce something saying this is definitively what we're going to do. Yes, we are a scrutiny body, but at the end of the day, a lot of reports come back, it's a fait accompli. There is no point in scrutinising what has already been produced.
Councillor Harris, Carolyn has offered to come back to committee. This is a preliminary update on the recent, on the partnership work that's happening, and she has offered to come back afterwards. She has also offered to circulate further information in terms of maps and also breakdowns of demographics and what we're doing in specific areas. So I just to
Yeah, look, to be honest, I heard of all of that, and I appreciate that. But there are some glaring omissions that we, the three of us, had sort of discussed beforehand. So I was just making sure that those three major ones were actually part of something that came back. That was all. But I appreciate the fact you will be coming back.
Thank you.
Councillor
Sorry,
Sanderson.
Councillor Sanderson, I'm Deputy Leader and acting Cabinet Member for Adult Health and Social Care. So forgive me because I know very little compared to my predecessor. Just to offer some reassurance, there are lots of different bodies where this will come through. So we've already had lots and lots of conversations about all of those issues. We're very live to them. And there are various plans in place that are going through the processes at the moment. So please don't feel like they're forgotten about in any way. They are just going through different bodies like the Health and Wellbeing Board, and then will, I imagine, come back through here at some point in the future. But please be reassured that there is very much work happening on all of these. So hope that offers some reassurance.
Thank you very much, Councillor Sanderson. Jim, please.
Yeah, in one sense, I can see what you're saying, Councillor, and I agree with it. One can't solve everything at the same time. But when you look at this quite helpful map of boxes, the first 4 lines of boxes, they're remarkably good for the borough because the borough is actually doing a lot, which really is first rate. It's the discrepancy in the final 2 swathes of boxes where you actually do find that in comparison with other much poorer boroughs in Northwest London, Brent, for example, we're doing worse. And for example, look, I'm quite clearly an old boy. Why is it that, for example, falls of people over 64, that's way back in my history, are so much higher in this borough than elsewhere? I mean, we're not more stupid or inelegant than older people. So there needs to be a breakdown there to mean anything, not recording facts, but how the facts are actually joined into a strategy. Else what we're doing is we're being passively pointing out what's happening rather than saying how we're organizing to stop things which everybody here wants to stop happening. So I would ask about some of the boxes. Is it the same group? Is there an overlapping between, for example, suicide and drugs? Between violent behavior and hospital admissions and that kind of thing. Unless they're kind of joined up questions come, in practice, nothing ever really happens except in small corners, which nuances a picture in a welcome way, but doesn't really change anything. So it's the action where you actually look at how the overlapping happens and how you organize, and this is hard, and Caroline's right, how you organize to actually turn the picture around. But that means strategy rather than just being passive about it.
Well, I think you'll be reassured to know that we're certainly not being passive about it. All of these issues, I mean, touching on suicide and drug use, I mean, there are so many nebulous reasons as to why any one person feels that suicide is their only option. It's a hugely complex piece of work to think about all the different routes that have taken them there. Drug use is one factor. There could be a myriad other reasons that because numbers are thankfully, although higher than we'd like them to be, are small, those individual cases can really, really skew different data sets. Are you, sorry?
Yes, sorry, Councillor, if I may, just picking up on your point, and the frustrations that people are, expressing. It is such a complex economy. We've got, our place-based director, but we also have got the ICP and the ICB, which aren't represented today. And Caroline is here trying to hopefully explain how she's going to get all these bits working a bit more smoothly together. One of the things that we've been reflecting on is just that there are lots of different strategies and lots of different action plans. So Nikki will be talking about the health and wellbeing strategy, which is part of it and addresses. There's the building trust, the sort of equalities, which is another piece of work that's happening. And of course, we know that North West London is developing its own, or refreshing its priorities. And that came to initially to Health and Wellbeing Board and is coming back there again. And I suppose one of the things we need to think about is how do we can't bring all of those in one go because it's so huge, but how can we identify the key themes to come back and update and bring back to scrutiny? And we're just going to need to think a little bit about that because it is so huge and you could end up with a massive document. It's also quite difficult for one person, I would say, to speak to all bits. And I think, Caroline, you included that as a sort of scene setter as opposed to being the authority on any of it. And I appreciate that you've got, very reasonable questions, but it is quite difficult. So if we developed a sort of thematic approach, we can make sure the right person is in the room. Caroline will be here because she does need to understand that. So I was sorry, Councillor, that's what we were thinking about just when you were speaking, but it was very much based on what.
That was much more eloquently than I was going to put it. These are hugely complex bits of work that are going to take time. Some of these issues are emerging, some of them we've known about for a while. So it is going to take time to build out those proactive strategies, thinking about all those complex reasons as to why any one of these have come together. And obviously, with lots of these negative stats, we know that with any one individual, quite a lot of these scenarios might apply to them. And that's why we've got to have a really holistic person-centered approach when we are thinking about really, really complex issues that are in the borough. I represent College Park and Old Oak. There is a very, very different quality of life for some of my residents than there is elsewhere in the borough. It's something that we're very live to. But because it's so important that we get things right, that we co-produce, that we work with residents to make sure we've got solutions and strategies that work, that's why it's going to take time. But that's also why we have to be selective about what comes through different committees. When there's really sensitive information about STIs, is a public forum the best place for it? I don't know. And I think that's probably a conversation that the committees need to have here at Health and Wellbeing Board and different forums that we've got to think about the most sensitive ways that we can approach some of the most sensitive bits of work that we've got. Thank you.
Jackie, please.
So just picking up on your point, Councillor, one of the things I know we want to do is to develop a forward plan for here, but also we can have a sort of just to note what has been discussed at the Health and Wellbeing Board so that you're aware of that, because there is a risk of duplication. And the Health and Wellbeing Board does have a particular statutory role in signing off strategies. And so I think if we had built it into this, so and at least we can refer to it, even if we aren't able to discuss it in detail for the reasons identified.
Thank you very much, Councillor Raptor.
Thank you so much, Caroline. I was just wondering, since the report primarily seems about kind of how the partnership's going to be refreshed and potentially restructured, whether you could speak in a little bit more detail about some of the problems that people spoke about when you were speaking to different partners, especially because some of the areas seem heavily in multidisciplinary prevention work. So some of the specific things that were kind of a concern.
I think the key theme is the fragmentation of services and the way that they're not integrated. And that increases the stress and the pressure on our frontline teams right across all our organisations, because they're more effort is spent in connecting than potentially could be the case if they were they work together more effectively, whatever that looks like. So you know, the whole range of different ways of bringing people together to work more effectively together, from informal arrangements through to, you know, integrated co-located teams. We don't know yet, but that was a key theme about that. And I think that I'm hearing a lot of evidence that people do experience those fragmented and disjointed pathways. So talking to a group of the health providers and GPs yesterday, for example, there are 3 dementia pathways in the borough, 3 different ones. There are 2 different providers of neurodiversity services and assessment in the borough. We have 2 hospitals, major trusts that do things quite differently. We have social work split from therapy, split from community nursing, yet dealing with the same people. And I think we do. So so to me, there's a whole bit around how we bring together services and support for people with more complex needs. And then there's the bit about the prevention and the wider determinants. And that's, of course, a continuum and a continuum through the life course. But that's where we need to select carefully, because there's a lot to do, but we can't do everything at once. And we can't do everything through the partnership. There will be some actions that the partnership has to leave to individual organisations to do and get on with. And bilateral work as well, of course.
Thank you very much, Caroline. So do you have a timeline in terms of coming back to HASPAC? Do you have some tentative dates as well? And also for the reassurance of the members of the committee as well. So when would it be a good time to get that update?
I mean, I think the forward plan's later on the agenda, so isn't it? So we can talk about it, but perhaps in a few months.
Brilliant. Thank you very much. I'm conscious that we've got other pressing issues to discuss this evening, and we've got guest speakers as well for the next agenda item. So thank you so much, Caroline. I welcome this partnership update and note the collaborations between health and care providers to improve health, care and well-being outcomes. So thank you for this update. And we look forward to hearing from you in 2025. Thank you. Okay, let's move on to the agenda item number 5, Disabled People's Experience of the NHS. And it's a report by Action on Disability. I would like to invite as well Nicolas. Are you joining us, Nicolas? Hello, Nicolas. Welcome, please. Are you going to join us? Please take a seat at the front. Thank you very much.
Should I start?
Yes, thank you so much. So, yes, I wanted to, first of all, thank Victoria Bringle, our member, for suggesting this agenda item for HASPAC. You made this suggestion a few months ago, so thank you very much for leading on this piece and working in collaboration with Action on Disability. I also want to welcome our speakers. We've got Nicolas and we've got Ashley this evening. So welcome both. Thank you very much for joining us.
Hello.
Great. So Victoria, would you like to introduce this paper? Thank you.
Sure. Yes, I'm Victoria Brignall, and until last year I was chair of Action on Disability. I'm still actively involved with them. So a few months ago, I asked Action on Disability to do some research into disabled people's experiences of the NHS. A questionnaire was sent out to members and a meeting was held to give their feedback in person if they wanted to. 26 people contributed, either by responding to the questionnaire or by attending the meeting and giving their thoughts that way. There was some positive feedback, you'll be pleased to hear. One person was praised for their GP for being very thorough, compared with a previous GP outside London. One person was very complimentary about their hip surgery and how well coordinated it was. Someone else received good support with their allergies. However, a number of problems were also identified. First of all, there is an issue with access to buildings for people with mobility impairments. One wheelchair user went to St Mary's Hospital and arrived to find that the actual department, but the point was, didn't have wheelchair access. So their treatment was delayed by an hour while that was resolved. People found buildings difficult to navigate generally. Secondly, there was a problem with access to equipment, disability-related equipment. So, for example, one person went to an appointment at Charing Cross Hospital, a wheelchair user, and needed to be transferred onto a couch, and found there was no hoist available. Not just in that department, but no one in the hospital had a hoist. There was a problem with attitudes of staff. Various examples. One person, several person, was in A&E, feeling very weak, and he was told off for lying down on the floor. Someone else had fainting symptoms and had her concerns dismissed as nothing to worry about. Someone else with ME was told that, well, felt that her condition wasn't treated seriously. Another person experienced rudeness regarding her gender identity. And there's a general feeling that receptionists were often unsympathetic and unhelpful. There's also an issue with communication. In one case, someone's records were, the transfer of records from one hospital to another was delayed, and as a result, the treatment was impacted. And someone else missed an appointment because their contact details were incorrect on the NHS system. So those are some of these other problems that people faced. Moving on to recommendations, the report makes a number of recommendations. Some of them are very obvious. As well as improving physical access, there's a need to improve the service that people with visual impairments receive. So with better signage, clearer signage, and more tactile guidance. There's a need for NHS staff to receive mandatory disability equality training. That should be all staff, both clinical and admin staff. And that training should cover the social model of disability. Information sharing between hospitals needs to be improved, and clinical and admin staff need to be better integrated to improve communication. There should be better access to treatments like physiotherapy and hydrotherapy, which became very beneficial to disabled people. And the need to improve the accuracy of medical records and make it easier for people to correct their mistakes in their records. But overall, there's a need to change the culture in the NHS so that people are treated with more respect and dignity and show more empathy for their situation. So overall, there's a cultural change is needed too. Thank you. I'd like to hand over now to Ashley Pearce, who's a member of AOD and will talk about his own experiences. Ashley, over to you.
Sorry. Good evening. It's Ashley Pearce here. I'm one of the, I'm visually impaired myself and I've got dyslexia, and I agree with Victoria as well. And also the other part, as I'd like to bring up, was I don't think we have the PALs are actually forthcoming in the services that they can offer. The same with independent advocates and the other services. They all seem to be hidden from us disabled people. And it's another service I think that should be, again, a joined up approach.
Is there anything else you'd like to say, Ashley, about your experiences?
Yeah, of course, being visually impaired again, going around the hospitals, it's quite hard to find. You can't always find the someone to assist you. Again, I agree with Victoria about, in my experience again, as a healthcare assistant, that so many times there wasn't the equipment to hoist the people onto the patient, to the beds or whatever services they need to be. There's always been delays. Again, the hospital transport, you're waiting hours to be seen. I'm not saying it should be instantaneously. People have been turned down and had to rearrange another couple of hours. It could be a day, it could be a week or a month for people to be have their appointments rescheduled. Again, and the other part would be accessibility, from a dyslexic point of view. Not all the information is provided in the chosen formats. And there has been, as Victoria said in the report, about communication problems. There's been duplications as well of letters that was confused people, that they said there's one appointment. I remember one time we was at the meeting, this person had a particular free doctors or hospital appointments all on different dates, and that wasn't confused where they were going to. And also from the administration part, it was quite confusing as well. Having to fill in forms, you know, there's elderly people, there's disabled people with learning difficulties and disabilities that can't fill in forms online, and you have to wait a long period of time. And also, there's only certain periods of time in the day that you have to phone up for to get an appointment, and we can't always do that. And some disabilities, of course, need assistance to do that part because of their memories and other disabilities. They've got to use the telephone from dexterity point of view.
Thank you, Ashley. I mean, I
Okay.
think what the report highlights is the fact that there's a need for co-production with disabled people in NHS. Hammersmith Council has pioneered co-production, and that is improving services for people with disabilities. And I think the NHS could possibly follow the example of this council and get disabled people involved in planning services. Hopefully some of these issues could be addressed and resolved. I'm happy to answer any questions you might have.
Thank you very much.
Sorry, can I just say one more thing as well, which
Of course,
I mentioned? Sorry, I forgot about from a deaf point of view, British translation, British Sign Language. There's not so many, as people may be aware, that can actually translate. And people have been flogged off by saying that I don't understand what you're saying. And they don't always talk, as we all know, they talk to the support worker and not us disabled people, which is very rude, but you know, it's always happened in life. And it costs about £50,000 for a British translator to be assigned to that part, when there are apps out there that I don't think are being used properly or are being awareness. And again, I don't think there's awareness again from disabled people that the services are out there. So I don't think the NHSs are doing it well enough to promote the services that are already there.
Thank you very much, Ashley, and thank you very much, Victoria, Ashley, and Nicolas, for the report that you have submitted for HASPAC. I wanted to thank as well the 26 people that have contributed with their lived experience to give us information about, I mean, very hard information to read, and it's very difficult to read the specific examples of some of the challenges and the challenges that disabled people are facing. So I wanted first of all to thank you for leading this exercise and raising awareness about the challenges that are facing. And I would hope as well that as a committee, we can try and help raise awareness about some of these challenges and hopefully get some response that can address some of these concerns. So Caroline, I know you wanted to come in. Thank you.
Yeah, well, I feel a responsibility as being the only person with an NHS badge around this table to respond a little. And thank you for the report. It was a really disappointing read. I'm disappointed that this is where we are. I think there's probably sort of some key themes through the report. And what I would want to say at the outset is to recognise that it is a time of historically low satisfaction with the NHS, and we know that that's probably not going to change that quickly. And some of the issues were around that kind of area, and we need to understand that better. And people are working very hard to try and clear planned care backlogs, for example, for outpatient appointments and things like for procedures, etc. And, you know, that we've just had the Darcy report on the issues identified within the NHS. And I think we do need an honest conversation about the way that the service is operating at the moment and the need to transform. And there is need for transformation. I think personally, that's all hard. It is really hard when, you know, you've served up your entire working life, and this is where we are today. So it's not something that as an NHS employee, I feel proud about, but I do feel proud about the efforts that people go to. What I found particularly disappointing, though, was the comments about access and the fact that we're not getting some of the basics right. And I think you're absolutely right to draw attention to that. I guess what I can't do is speak on behalf of the providers here, but I think that it'd be really helpful to talk to you outside here and understand some of the hotspots, and perhaps then we can connect action on disability with the right people in those provider organisations to start that conversation about what difficulties are being experienced and how we can put them right.
Yeah, thank you for your words. And obviously, we know that NHS is under a lot of strain at the moment. The resources are limited, and we know that change can't happen overnight. And we're also aware that it's a very complex organisation, lots of branches involved in it. And as I say, I think we just need to start to the wheels of change turning, and AOD will be very happy to cooperate with you on and making things better. And as I say, I think there's some recommendations which will cost money, but also there's some that could be achieved quite cheaply. Better signs, for example, and hoists are quite, in the grand scheme of things, are quite cheap. And so I think it might be worth setting up liaising with AOD to some sort of co-production project, so that people can come along and advise the health service, the different parts of it, and what needs to change.
Can I also suggest something else? It would be good to have some sort of engagement with the health and social care providers, like in the hospitals as well, from lived experience. If we could have the opportunity to go there, different disabilities possibly, to have an open policy transfer, what they call it, transparency would be fantastic in that respect if you could do that. And also if there would be any opportunities that we could come back in 3 months to 6 months as well to see if there's any progress that's happened. If that's any ideas.
I think this is work for the providers, not for the partnership, because they need to focus on fixing that within their organisations. So if we take it offline to have a conversation about where the particular issues are, and we can start perhaps with the worst and start working it through. Yeah.
But I'm keen to suggest as well, in terms of our role, whether we could potentially have next year, maybe half a day, we could all come together and explore with the NHS, with Action on Disability, and other key stakeholders, our ways of working, ways in which we can actually have a more focused approach and learn about the specific examples that we were given today and the solutions that are coming from from disabled people as well, and maybe having a half a day or conference event focusing on this would be a good solution, or a good way to try and mitigate and find some answers. What are your thoughts on this suggestion?
So sorry. Yeah, I was just saying, I think that's an absolutely fantastic idea. It would certainly help me as a counsellor, and I suppose other counsellors, to actually even understand the fragmentation which has actually taken place and what that looks like and how that can be repaired. So I'm definitely up for learning from you guys. Yeah. Oh.
Yes, Jim, please go ahead.
I think it's quite important that good ideas which have come from Victoria and from Ashley are actually taken forward. Reading this, and I'm speaking as somebody who's pretty obviously old, but I'm also partially sighted, that there are obvious things, if you go to the acute board in common, that you actually get anytime disability comes up, people are sympathetic, but little happens thereafter. I think of obvious things, for example, talking about hoists, that working with the hospital services, but also with GPs and with disabled people, you could run co-production on an equipment audit of what are the most common needs for disabled people. And that's quite easy to do. But it's not just hospitals we're talking about. So the split between providers and the rest, it needs to be broken, else it will go on forever. It's also GP practices. There are barriers to get into some GP practices around here. So if there's to be half a day, it needs to be a workshop, in my view, led by disabled people who will have got together beforehand, who need an agenda. The NHS, to use a cliche, is like turning a ship around, a big ship. It only turns around when people push very heavily and strategically at places where you want to get. Otherwise, people will agree with you and do nothing. So I'd suggest to Ashley, to Nicola, to Victoria, that taking up the suggestion there, which I think is an excellent one from the chair, that identify a day, but get together beforehand to work out what it is you want, and to ask the providers, the acute boards in common, to turn up with GP reps to work out what needs to change in what order. And some things can change pretty cheaply. Some things cost money, but actually do save money in the long terms. But unless it's done like that, you will get sympathy, but no change.
Thank you very much, Jim. I think that's a very good suggestion. I mean, we want to encourage a culture of co-production, doing things with residents, not to residents. For us, this means that disabled residents and community resident-led organizations, officers, and NHS partners work together equally to co-produce solutions. So hopefully, this activity will help us with that. I know we have with us Tara, our co-production lead. From using your co-production, thinking about the co-production lead role, Tara, I wanted your thoughts on the suggestions that we're having, and if you've got other further recommendations as well in terms of what could work well for next steps, please.
Thank you, Councillor Perez, but can I say a huge thank you to Action on Disability for bringing this report to HASPAC and to the attention of everyone. I think it's an issue that disabled people have experienced for decades. This is not a new experience, not being able to gain access to vital and often emergency healthcare services. But what I think is important about today is that it gives us an opportunity to draw a bit of a line in the sand and say, can we get together and think about how to start to make a real difference? But as other people have said, so there's no point repeating it, doing that with disabled people who have experienced many of these barriers, I think will get the best result. Because I think, Jim, I completely agree with you, Jim. I think what we don't want as disabled people is sympathy for the terrible situation we often experience in hospitals, GP practices, dentists, maternity services, and the list goes on. But what we really want is to be able to share our ideas for how things can be different. I think we are experts by experience. Many of you will know that phrase, but I think it reflects well for this conversation. So anything, Councillor Perez, I could do to support that, I'm more than happy to. We've got lots of good practice that we can share here within the council.
Thank you very much, Tara. Definitely, let's follow up and help develop this next action. Thank you so much.
Could I make another suggestion? Could we do the same thing with the sexual transmissions? And as it's a mental health issue, could they have another sort of potential day that they could have that, or half a day conference regarding the awareness and everything else as well?
Thank you, Ashley. Councillor Sanderson?
Well, I was going to say we had a conversation. So I'm chairing Health and Wellbeing Board at the moment about this half-day conference and actually having that. So it's bringing together some of our inequalities work streams and looking at new ways of working. So we've obviously got our Building Trust with the NHS project going on at the moment with the Black community, which is brilliant work. And so having that as part of this half day. So I think there are probably lots of different threads that could come through here. So if it's all right with you, Chair, maybe having a conversation as the chairs of Health and Wellbeing Board and HASPAC to think about the agenda, and then sharing that with the different committees to think about some of the work streams that could come through the half day. Great.
Yes, let's do that then. Thank you very much. Are there further comments or questions? Yes, Councillor, absolutely.
I was just wondering, given that one of the most common suggestions was about training, whether we have knowledge really or an audit of what training actually happens across the borough and what works. And yeah, what works effectively. I don't know who would know. I mean, thinking about how many different teams are involved in that, I'm not sure how. we go about that.
I mean, I guess that's the point that I'm making really, because the report, I mean, really sensibly for a published report, it sort of didn't name organisations. We'd need to get underneath where the issues are to actually understand it. I certainly heard from one of the providers that they feel that they have comprehensive training, but I can't match that with the experience until I've had that offline conversation. Yeah, so I think we just need to give that a bit of a chance to see if we can get some interest from wherever the issues are. I heard Charing Cross mentioned a number of times, so you know, perhaps that's a good place to start. And it is a well-resourced organisation, and you know, I'd be confident that they will take it seriously. But I'm happy to broker that conversation. But as I said at the outset, I am very conscious that I rely on the resources of all the partners, and resources are stretched, and I don't have any of my own to support any of these work streams. All I can do is broker and convene.
Thank you very much, Caroline. Okay, well, thank you. Just to reiterate our thanks to Action on Disability for bringing this paper to committee and raising awareness about the difficult challenges being faced, and also exploring collectively solutions. So we've agreed some next steps in terms of what we're going to be doing in collaboration with Action on Disability. We're going to have a half day conference looking at how we can hopefully find solutions as well going forward, and also input as well from our co-production lead, Tara. Thank you as well for your suggestions. Thank you. Okay, so let's move on then to the next agenda item. Agenda item number 6, Hammersmith and Fulham immunization and vaccination briefing.
Thank you very much, Chair. So this is an update paper. If members remember, in November 2023, we had a scrutiny of immunisations performance, and we invited NHS England and also the Integrated Care Board just to remind that NHS immunisations coverage is the responsibility of the NHS, but we work in very close partnership with them. The slides we've prepared today are not an immunisation improvement plan. They are just a snapshot of work that we are doing. So I was going to talk through a couple of the first slides and then ask my colleague, Dean Lindsay, who's one of the public health nurses, to talk through some of the exciting work that's happening in our nursing homes, and then take any questions. So colleagues, you know that there has been long-standing low immunisations coverage for over 10 years in Hammersmith and Fulham. And we know the types of residents who have the lowest coverage. That's on the first slide. The second slide talks about what we call herd immunity. So WHO standards are that we want to be at 95%. We are very much below that. And immunizations in the last few years have taken a hit across the whole country in terms of coverage. What I was going to do, if it's okay with colleagues, is hand over to Dean Lindsay, if he can introduce himself. So that's from page 28 onwards, to talk about what we're doing in care homes, and then on working with residents, and then some more detailed work that we're doing, and then take questions. So over to Dean, if that's okay.
Okay, hello everybody. Dean Lindsay, Senior Lead for Infection Prevention and Control. I have the portfolio for IMS and VACs. I work under Nikki within public health. So it's a great pleasure to be here, and thank you very much for the invitation. I think the first thing that I wanted to bring up is the fact that when I came to work at H&F and somebody said to me, would you like to take on IMS and VACs? They sort of said, we've tried it all, it doesn't work, we're terrible, we're the worst place in London. That's it. Okay, let's put the record straight. No, we're not the worst place in London by any means. And actually what we do is very good. We do a lot of great work. We've got a lot of innovation going on, and we've got a lot to be proud of. What we have tried to do is to look at what we can do to try and improve immunisation and vaccinations within our community. Now, this is not we're bad and everybody else is great. It's awful everywhere. So there isn't a place in England where they have a really good performance on immunisations and vaccinations. So we can't point to someone and go, they're really great, let's be like them. And there is no magic wand. So there is no, we'll do this and everything's going to be better. What we have to do is treat this like a running race or a cycling race. It's about marginal gains. It's about lots of little things that will work together to help us to improve. And if we work together and join up and communicate and share our resources, we can have an exemplary service here. So one of the things to do is to take certain areas and look at those in particular and try and find what's going on and see how we can make improvements. So my colleague Lizzie Naylor came in 3 years ago and started looking at flu vaccine uptake within care home staff. Now, we were the worst performing borough for flu vaccine uptake in care home staff. It's obvious we want to have staff vaccinated because the risks of transmission, both to service users and for people taking them home. So we want to try and mitigate any sort of comorbidity from that point of view. We've implemented a number of studies there. So we've put research, novel research. This is research that's not been done by anybody else, that's been generated here in H&F. We looked at why staff don't vaccinate. And from that, we've learned, we've implemented, so we've offered specialized targeted training. We've looked at where people can get their vaccines from. We've looked at what their hesitancy is about. And from that, we've developed interventions which have helped us to work with the care home staff. I said to you 3 years ago, we had the worst performance in uptake of flu vaccines in care home staff in the country. Last year, we had the best performance in the country, not just in London, in the country. So we were the highest performing uptake of flu vaccines in care home staff in the country. So we can make improvements, we can implement things, and we can make changes. We work with residents, so we understand that it's not just about we'll come up with some great ideas and everybody's going to pick up on those ideas. They're not. Everybody has different experiences. We have a rich, wonderful, multiple culture in our area here. People bring experiences of health and care from the countries that they've originated from. I can remember how I grew up in East London. If you're unwell, I grew up with my grandmother. If you were unwell, she gave you a spoonful of butter. That made you better. If you were really unwell, you got a spoonful of butter with some sugar on it. You really thought you were living then. So that was my experience. Nowadays, if you say, give someone some butter, they'll go, oh my God, what are you doing? Think about their cholesterol. We work with residents very closely. We want to understand their experiences, and we want those experiences to be used with the community. So one of the things we've done is we've got some of our local residents to make videos. We use those videos on our social platforms. They speak about their experiences. For example, we have a lovely lady called Amal. She's been talking about MMR and the impact of measles on her extended family, and how the fact that some members of her family didn't have the MMR vaccine, and how there would be a value if people did have it. So we have these, there's a great deal of information going on why you shouldn't vaccinate, all these sort of scare stories, but actually we miss the reason why we vaccinate. We prevent disease, and that's what we really want to do. We're working on pertussis at the moment, and we're also trying to factor in a whole group of ladies. Ladies are quite useful to talk about health issues, and get them all to talk about different vaccinations, different impacts. And we're going to do 1 day of videoing because we can then rotate on our social platforms. And we know this works well. The first weekend we put Amal on the platform, we had 1,000 hits. That's jolly good. That's people learning about what's going on. We want to improve the access to vaccinations, so we work very closely with the roving team. So we have a roving team across the borough. They go out and offer vaccines. But one of the things that they've often come back to us and said historically on other sites is they go places and nobody wants vaccines. They give out a lot of leaflets. Leaflets don't prevent you from getting diseases. Vaccines will do that. So what we did was actually look at the logistics. Where do you go? How do you engage? How do we prepare that area for the intervention that's going in? The first session we did was in one of our asylum hotels. The roving team had done 26 sessions in other boroughs. They'd given one vaccination. They did one session with us in our borough. They did 13 vaccinations. That was a pretty good turnout for one day. We now have the roving bus going around at various different sites. They've done a number of different sites this year with very, very good uptake. So we're looking forward to seeing what our numbers are this year. We've got a community pharmacy project being set up. It's been slow because there's a lot of issues, particularly around IT and communication of information about data so that people understand what people have had before in the past to make sure we don't duplicate. But we now have 3 pharmacies that are going to be set up within H&F to be able to offer MMR additionally to the other vaccines that they do. This is good news. It gives people more access to vaccine services. We run the Haferivax training. You may have heard it. If you haven't, I would love to welcome every single one of you to our Haferivax training. This is a training essentially developed by 2 universities looking at why people have vaccine hesitancy. That's great. What do we do about it? How can we overcome that? What we need to have is constructive conversations about vaccine hesitancy. We know why people don't vaccinate, but we need to understand how an individual doesn't vaccinate, because it's not just a big paintbrush you can put across one particular culture or one particular group. It doesn't work like that. So we do our vaccine hesitancy training. It's a full day. It's face-to-face. There's no teams here. And you actually learn about why people have vaccine hesitancy. And then we develop the skills in having the conversations to help people make a decision for themselves. It's no good me sticking my old white coat on and going, look, you're an idiot. You need to do this because everybody knows vaccines are great. That doesn't work. People don't want to be talked to like that. We need to find out what people's hesitancy is about. And on that basis, we can then help them to change their opinions. I would welcome every one of you to come to our training. We've trained more than 100 people so far. We do it every single month, and we would love to see you there. It's free. Finally, we have the Vaccinims group. So we've set up a vaccination and immunisation group, which we run on a monthly basis for health H&F. And the joy of this is to bring stakeholders together to look at our performance in vaccines and IMS, and to more importantly, look at our good practice, because the most important thing is to look at working in a joined up manner. It's okay, people doing great things, but we need to share what works. And we need to be able to look across our rich community and work out what works with certain communities and how we can target our resources most appropriately. Fact of the matter is, we're doing all right. We're certainly improving, our numbers are improving, and the most important thing now is to make sure that the data backs that up. So we've got our BI team working on tightening and cleaning up the data to make sure what we do is being reported properly. Thank you. Love to take any questions.
Thank you very much for the update, and it's great to hear about what's working well and how it has improved, no? And hear about how Hammersmith and Fulham now has the highest uptake of flu vaccine in care home residents and staff in the country. That's really good. Also, the work with the roving team and how you're working with residents and the training and how that's having an impact. Thank you very much, Councillor Lloyd Harris.
Thank you very much. That was actually a very impressive report. I'm so glad that we're heading in the right direction. So well done to everybody that's working on this. Just a couple of questions. One may not be particularly politically correct the way I phrase it, so apologies in advance. The first question is, it's about the asylum hotels. Now, did I hear this correctly that you've been to one or have you been to all of them in the borough? And if you have, what's the uptake been? What sort of reactions have you been getting?
Dr. Lang.
No, that wasn't the difficult question.
Okay.
Is there anything, sorry, that's I thought was a genuine question, actually.
Dr. Lang, do you want to come in, please?
Yeah, we tried to keep confidential the location and the
No, I'm
number
not-
of immunizations
sorry, with-
given in location. So I'm
Okay.
sorry that we said that. We shouldn't have.
Okay,
Yeah.
I'm not asking for the addresses. I know where most
Yeah.
of them are, so that's not what I'm asking. I'm asking for a general view on, have you been to all of them and what is the general uptake? It's what we would ask for any other community. That was a genuine question, because I will be asked that about this, because people have read the report, and I think it's reasonable to ask it. I don't want names and addresses.
Thank you.
Okay,
Yeah,
okay,
I think understandable. Do you want to answer that one just so
Yeah.
you're comfortable with the information?
Happy to do that. We have been working with the communities, especially since 2021. One of the baseline things that we've had difficulty doing is establishing people's vaccination status that they've had in their own country. So a lot of people that we've spoken to say, actually, I had everything done in X country. Why am I having it again?
Mhm.
There are NHS regimens for people who are coming freshly to this country, which are just called catch up, which are really nice. We've been commissioning general practitioners to go into our hotels, I won't say which ones, to do catch up.
Mhm.
And when people become more confident, then they can walk across to the GP practice and have their catch up vaccinations. So the roving activity that Dean describes, they're not meant to be the normal way that people receive vaccines.
Sure.
You can imagine, Councillor Lloyd-Harris, once you get more confident, you're in your neighborhood, then you know that you can go to your GP practice. It's a combination of confidence building, people meeting Dean Lindsay and hearing, in a culturally competent way, and then going to their practice.
No, thank you very much. I appreciate that. Now, the question that might pose a problem, I'm not sure why it would, but does the government, and I really genuinely don't know this, does it have a view on inoculations, immunisations for asylum seekers generally? Because obviously in a bygone era, and I'm talking about a century ago in other countries, it was if somebody's coming into the country, then obviously you would check. But if there was any doubt, they would say, well, I'm sorry, you either can't come in or we do our vaccinations at this stage. Now, I'm not suggesting that happened here. It used to happen in the States. So I was just wondering, does the government have a view on this?
I can't speak for the government. I can ask Dean. We don't have sort of entry port health requirements because the research has shown that it doesn't work. But what we do, and having spoken to a lot of asylum seekers, is we just say, show us what you've got. These, even when I did my public health training a long time ago, there are really good tried and tested catch-ups. We can show you the algorithms. They're all online. I've come from this country. This is what I think I've had, and then you basically get everything done freshly. I think what we find as well is it's people getting to trust us, isn't it? We've got phenomenal GPs in this borough. The ones we send in are the best. I'm so proud of the work that they've done. They're friendly. They are so awe-inspiring. They build the confidence, and we also do things in culturally competent ways. So offering a non-pig version of MMR vaccine. So yeah, it's about you're here with us now, and this is the way to catch up. But in a way, the asylum seekers are like the rest of the population. The people are scared of vaccinations now. So some of it is they meet Dean, they see him, and he's a nurse, so they gain confidence.
If I could add to that, I think basically there's no special service for anybody. We want equity. So for all of our community, we basically want equity. So and that's exactly what we're trying to achieve.
Jim, please.
I was really pleased to hear about the direction of travel, because we have historically not been very good, and it sounds like we're getting better. I worked in schooling, so I'm a question about how you're connecting with parents and kids at school level. And I say that because I know that schools were very often trusted places for all kinds of aspects of NHS, where somebody addressing children, that got parents, generally the mother, but not always, involved. And that was often a very good transmission way for breaking down myths, barriers, hesitancies, and so forth. So it's a question for children's vaccines, immunizations. I mean, I think they're the key ones to start with. What kind of experience have you had there?
Okay, two answers to that. Number one, we've got a new organisation that's come in to take over doing school vaccinations called Vax UK. So that's a private company that's providing services. This is their first year, so they've only been in from the start of November, and essentially they seem to be doing a good job at the moment, but it's going to take time to collate the evidence. They have quite a dynamic way in actually offering vaccinations. So they've got a central hub. They're very interested in whether people want to have a vaccine and don't, how permission is given, and how they can actually support people to make the decision to do that. They also front up the fact that there are non-porcine vaccines available, so for example, for flu and for MMR, so that's very useful as well. Secondly, I think we're very aware of young people, not just parents, because I think one of the things that we've seen that changes now is that, as previous speakers have said, quite a lot of people will get their information and access to health via the internet, via electronic services, platforms that I definitely don't understand. And so what we're trying to do is also build services around the needs of young people and actually getting young people to be advocates. So this is very early work, but we're looking at developing young people advocates who will be able to talk about health issues, particularly about vaccines and immunizations. One, to be able to instruct their parents and talk to them, sort of in a reverse process, because they can help them to navigate the pathways that are quite complicated, but also to help them to bring what their fears and anxieties are, as we saw with the previous group that spoke, that people have specific needs. And also we recognize nowadays that there's a lot of issues around Dr. Google. You know, people know what's wrong with them and they know what they want before they turn up and see a clinician. So it's about helping young people to make good decisions. Early work, but we've actually got the structure going in place to do that.
Thank you very much, Dr. Lang.
Yeah, just to make a quick comment, we can't rely on the school system because when we need them to have their immunizations from 2 months even. So school immunizations is nice, but it's too late. We want them to be covered, as Councillor Lloyd Harris says, with the normal schedule from when they're able to, from babyhood.
Just one quick question. I know last time we had a lot of data and these sort of slides. Is there going to be a bit of data?
We are.
Data's just quite helpful.
We are
to
happy
see
to, yeah. And
how it has progressed.
I'm cautious. We can't say we've solved it. I wouldn't say that if we've gone up 1%, that isn't good enough. We've got a long, long way to go. But yeah, thank you.
Thank you, Councillor Apter.
Yeah, I was just wondering what the outreach is for the training you provide, because it sounds like you're not just looking for health professionals to take it, and if you could speak about some of the other sort of people you'd like to complete it and how you're connecting to them.
Yeah, so the Heferovax training is probably more aimed at social care staff and health staff. What we're doing at the moment, which is really exciting, is we have a family champions program, which is in family hubs, which is a fantastic innovation from Children's Services. What we're looking at is skilling up maternity volunteers to then have those conversations. And that's going to be a slightly different training program. So less focused on the complexity of the conversations and more confidence building.
Can you please tell us, oh, sorry, do you have a follow-up question? Okay. Can you please tell us what has worked well with care homes? Well, I know that we've got the highest uptake of flu vaccine. So what has worked well to achieve this, which is very good news?
Yes, I mean, just to say, if we're the highest in England, it's still only about 30%. So just to put it in context, yes, it's good to be highest, but actually we're nowhere near where we have to be. I'll hand over to Dean, but in a nutshell, it's about listening to people's concerns. A lot of people who are social care staff thought that if they got vaccinated, they'd feel unwell the next day and lose money. So really simple concerns like that we sort of had to address with the nursing homes. I'll pass over to Dean. Did you want to? There were other reasons too.
No, so exactly. I mean, one of the things that was surprising is Nikki says it's a lot of socioeconomic stuff. So people were concerned about losing work. And if they're off more than, you know, to still be paid, they have to actually have a whole week off, and they don't want to be off for a whole week. So we've spoken to employers and said, look, this is something that's important to people. How can we factor in the fact that they can have this done without necessarily losing days work. Try and get it done during the working day. You then go back and you can continue your shift, and actually then you work your way through your vaccine very well. We've done a lot of targeted training, so we've talked to people about what vaccines are, help them to understand how they work, help them to understand how to manage the side effects that are associated with vaccines, and to recognize what is good and what is not good. To try and demystify it, because a lot of the problems that we have with vaccine pushback is down to misinformation. So we've done a lot of that. We've taken the vaccine bus to care homes and said, look, it's parked outside. You've got a coffee break or a lunch break coming up. Your company will pay you an hour if you go out and do this. Go out and do it. And they go out and do it. So as we say, we haven't got 100% uptake. We've got the best uptake in the country, and it's still improving. And that's what we've got to do. It's a work in progress, but the evidence is that you can turn these things around and you can make improvements.
Thank you very much, Lucia.
Is it exclusively flu? Is it flu and COVID?
Flu and COVID.
Oh, just flu and COVID.
Okay, thank you very much. Are there further questions, comments? Okay, well, thank you so much for this update. I think we all agree that we're heading in the right direction, and there's still work to be done, but it's very good to hear of the progress, and also how you're working in collaboration with others as well to get to the rates higher. So thank you very much, and we look forward to getting further updates afterwards. Thank you very much, Lynn. Okay, let's move on to the next agenda item number 7, older people's care homes in Hammersmith and Fulham. And I think we've got Julius with us now. Welcome, Julius.
Thank you very much, actually. I mean, that nicely segues from Nikki and Dean's paper into ours, actually, given the good work and collaboration we've done over the years. Our paper is an update, and it aims to give a picture of the landscape in Hammersmith and Fulham care homes. But I won't say too much before I hand over to Johan, because Johan and his team have worked quite hard over the years, working with our care homes in partnership, but also just trying to ensure that the quality of the service they deliver is what's expected. So I'll hand over to Johan, if that's okay.
Thank you, Julius. In terms of presentation, I'll very quickly go through that, if that's okay, Chair, and then any questions. And really the first slide is all about a care home is regulated, but very importantly, it's someone's home. It's not a hospital bed where you get in and out, it's someone's home, and we need to treat it as such. In Hammersmith and Fulham, we have, for older people, we have currently 5 homes. Very recently, one has arrived, so to say, but many of you will be familiar with St. Vincent's, Farm Lane, Nazareth, and Chiswick Nursing Centre. The new one is called KYN Hurlingham. If you look online, if you search it up, it's a lovely, lovely building, but also rather expensive, frankly, and we don't place in there because of the cost, effectively. The other part is that as a council, we struggle a little bit with capacity, and we place a number of people outside, and you've got the numbers there, and it's really about 60% we place in Hammersmith and Fulham over the last, given the data, and 40% out of borough. Sometimes being out of borough is the right thing, by the way, because of family circumstances, and people choose to go out of borough. But where possible, we really want to have Hammersmith and Fulham residents cared for in Hammersmith and Fulham. As part of our quality assurance, we do a lot of activity, and I won't go through all of these. The two I really want to mention is that we do have monthly what we called joint operational groups, and these are really multidisciplinary conversations with both the NHS, one of my teams, care homes, and people like safeguarding, all coming together to look at the quality of the care home and going through the issues that present, including key performance indicators, safeguarding issues, etc. Lastly, or not quite lastly, but getting there, we very much put the resident at the center of the care. So it's very personalized, but that is also reflected in where people want to be. And what we need to do as a local authority, and we do, is to make sure that when we place people in a home, it has to be CQC rated as good or above. There are very few exceptions to this, and that really has to do with if a particular choice had been made around a particular home in a particular area, and then we do a lot of due diligence and work very, very closely with the family to make sure that wherever they're placed is their choice, but they are aware of any risks that may be attached to that when the home is requiring improvement. And the presentation doesn't say this, but if the home is called inadequate, there's a whole different procedure that goes with that, and we certainly won't place in there. We actually will take people out of those homes when that happens. Lastly, we like public health and vaccinations, there is always a program of continuous improvement. And again, you can see the activity there, but we very much want to focus on kind of workforce skill. We need to make sure that when we visit, we inspect the rooms and the bathrooms and make sure that infection control procedures are followed. And we work very closely with Dean and his colleagues on that. We check how many activities are being done with the resident, and again, how much choice they have in that. And very importantly, people with dementia, and of course there's a whole dementia strategy, but we really want to focus when people have dementia that the care is appropriate to the person in that regard. So we very much make sure that the care homes and the staff are dementia aware and have champions within the home. It's a very, very brief whistle-stop tour. There's lots more I could say about care homes. I'm very aware of time, so very, very happy to take questions.
Thank you very much, Johan. Thank you very much, Julius. I really welcome the focus on the quality assurance, the joint operational groups as well, focus how residents are at the center of care and how their voices are important and the choice that they have is so important. Also that they're placed in care homes that are assessed as good by the CQC. So thank you very much. It's a very welcome report. Councillor Lloyd Harris.
Couple of questions. Chiswick Nursing Home. Am I reading this correctly where it says all of the beds are private, or do we actually have a number of beds that are allocated for our residents? I'm very impressed to see it's finally got a good rating because there's been a lot of work, a lot of resources and investment put into that care home, nursing home. So do we have any beds there?
Yes, we do. At the moment, if I can give you the specific data, but we do have about 20 to 30 residents in there.
Okay.
But as a home, it's catered towards private residents rather than beds purchased by the local authority. Okay,
no, that I sort of understand, but it'd be nice if we can put that in, just because it might actually sort of help people with other questions that would follow. So that's a vast improvement on what's been, because to be honest, as far as I'm concerned, I think the previous director, who shall remain nameless, it was pretty much a basket case. So this is really positive news. Could I suggest then KYN, given the cost of it, I've inspected it, invited to champagne and opera night, as a lot of other residents were invited to, which is fabulous. So, if maybe that's where I'll end up. I don't know. Anyway, I don't know. Hopefully not. Can I sort of suggest that, or ask, why is it on the list? If there's absolutely, and I'd have to say what I've seen, there's probably not a lot of chance that we can have that sort of resources to put people into it. Is there a reason why it is going to probably sit there or not?
Absolutely. As a local authority, we have a responsibility for all our care homes. However, challenging the financial situation is for some of those residents and being placed there, we do have responsibility to quality assure and to make sure that the care is appropriate for the residents, regardless of the cost. It's a very new home.
Oh, I know it is. It's in my report. Very well aware of it.
We still need to we're getting appointments in place to make sure that we visit and we get a good sense of what's going on.
Do we have a sense of when it might be inspected?
I can't speak for
I'm
CQC.
not gonna hold you to it, but.
So I can't speak for CQC.
Okay.
But we certainly will do our visits.
Okay, thank you
Julius.
very much for it.
Yeah, I was just going to add actually as well, what we've learned over time is, you're correct, Johan, we make sure we capture all of the care homes within our geographical patch, but build a relationship with them. And that's just so that when things do go wrong, because as we know, they do, it makes it a lot easier to go in there and with that partnership you've built to put things right really as well. Yeah, so
Doing a lot of outreach work as well. And I know they're working with Hurlingham Club to sort of ensure that it's well known that it is there if people get to that stage and they want to hopefully try and stay local for family reasons. But yeah, okay, no, I'm interested to see it there.
Jim.
Thanks to Julius and to Johan for the report. I must say, unlike Councillor Lloyd Harris, I've never been invited for champagne. I'd sent for a few beers myself, but nobody's ever invited me. But I was quite impressed by the quality assurance about your continual visiting, looking at what's happening, is it adequate or otherwise. That really is quite important to hear that. And I think a lot of residents would like to hear that because it's good news. Now, I don't think care homes is an intractable problem. If the government were to put its mind to it, it's a tractable problem, but it's getting more difficult, I know from national diagnosis. There are several things I wanted to ask which are not in the report, and I don't think they're outside the scope of it, of continual improvement. There's an obvious one about staffing, because I know the national picture that care home staff, the turnover is immense. Very often, because turnover is immense, training is not very good. And that's not something one borough can solve by itself, but it's one where it can be fed upwards. A second thing came up is this: 230 residents from the borough in care homes at the moment. What's the relationship between, if you like, supply and demand? Is demand in excess of that, or is this a good number? And I was wondering, beyond that, is what's the time lag between looking for a bed or a place in a care home and actually getting one? And there's an obvious thing, because one thing I like about the borough, it's very much an equalities borough. I'd be curious to see a breakdown of the residents in terms of social class, of ethnic and cultural background and so forth. So we actually do know that we're actually covering the real demography of the borough, that some groups aren't losing out very badly. And I'm sure there were kind of questions you had in your own minds when you went around, but it would be useful if the information were shared, because then you'd have a notion of where we want to go.
Thank you very much, Jim. Yeah, I mean, this is information we could always bring back. Because we didn't
do.
Yeah, we could always bring them back. I'd try to address some of them though preliminarily. Demand and supply. We know as a small borough we've only got 4 or 5 care homes in the borough. We do. So that in itself explains the fact that the demand is greater than the supply. It's not helped by the fact that we've got some of the homes, Chiswick being a typical example, and now KYN, that are too expensive for us, and therefore we have to actually almost rule them out of the picture. But we are doing a lot of work internally as well, and around trying to make sure we look forward at what the demand will be and try to actually legislate for that. A typical example is we're working very closely with our planning team in economy. They alert us quite early once there's a planning application that comes in, and then we meet with them to see what we can do by way of influencing what those beds look like. I can't say we've had great success, but the fact is at least we're having those early discussions to see what we can do there. In terms of finding the length of time to find a placement, due to the demand and supply imbalance there, it takes a little longer for placements to be found, and even more so where the needs are much more complex. But our brokerage team are quite effective and have very good relationships with the care homes in borough and surrounding boroughs as well.
Thank you very much, Julius. We've got a Director of Adult Social Care, Catherine.
Thank you, Councillor.
If I can go back to Julius, there was a couple of parts of the question which weren't answered about the social background of people. And I think that's quite important because the ethos the council tried to drive, often successfully, is that of inclusiveness. So a breakdown of what residents get help and which groupings you think are losing would really be helpful.
I think Catherine wants to come back on this point.
Yeah, I'll just mention that wasn't the original point, but I will come back on that. So we do have information about which residents go into care homes. Not everybody needs a care home. It is a small proportion of the people who we support that actually need to be admitted to a care home. We support people at home for a very long time before that happens, but we can certainly come back with some of that information. I just wanted to pick up the point about timeline for the placement, because as Julius said, it can take a little bit of time if someone has very complex needs, but it can also happen very quickly as well. It depends very much on the needs of the individual and the needs of and what's available for that individual and where they want to go to as well. So some people, as I think Johan said, want to move other parts of the country because they have family there or a connection there. Other people want to stay in borough, but we certainly do move people very quickly sometimes when we need to.
Thank you, Catherine. Lucia.
You stated that you only place people in good care homes. And just notice, I mean, Farm Lane requires improvement. What steps are you making to bring that back up to good? And does that mean that you're not placing anyone there in the interim?
Thank you. Really, really good question. Farm Lane was rated as good, but they had an unannounced inspection and a number of issues were found. CQC fed that back to us, and our quality assurance team and my care home commissioner have worked very, very closely with Farm Lane to rectify those issues that were there. One of the things that, for example, happened was to have an additional night staff to make sure that the quality of the care is good. There has had an action plan with lots of actions. We follow up monthly then, or actually fortnightly with the care home to make sure that those actions are completed, finally signed off. Of course, we can't change CQC rating. That's something that CQC needs to do, but I'm confident that if a CQC would go in now, it would be rated as good.
Thank you very much. Jim.
Could I make a suggestion? You're probably aware that the ICB is beginning to undertake a kind of consultation on end-of-life palliative care. And care homes are not just that, as we all know, but there's an overlap. And I suggest it might be worthwhile putting your oar in, because you've got information and potential influence on whatever decisions are come to at the end of the process. And it's important that people like yourselves who are knowledgeable actually bring knowledge rather than pre-cooked ideas.
We are engaged in those discussions as well. Yeah, thank you.
I've got a question, please, on quality assurance. So how often is the quality assurance team monitoring the care homes? Is it on a yearly basis, or what's the process of checking that they're meeting all the requirements?
So from our perspective, we in essence do that at least on a monthly basis through our joint operational groups. That in some ways is our main focus, but we do also have announced as well as unannounced visits. We aim to do that at least quarterly, both announced and unannounced by care home. But of course, if there are issues found, we will reassess that. But part of our quality assurance, particularly on the visits, is that my team is visiting all our care homes on a very regular basis, mostly announced, but certainly at least once quarterly unannounced.
Thank you very much. Julius.
Just want to add a nuance to that, a positive nuance actually, because one of the things, or the time that CQC went in and found some failings in Farm Lane, I think they must have gone in about 5:30 in the morning. It's quite an interesting time, but a really good time as well. And on the back of that, over the last year or so, we've been thinking hard about how we can vary the time we go in as well. And so as we speak, I think we're just finalising for staff to go in unannounced in early hours of the day as well. And at least that would be to start off with at least once for each care home. And then we can, from the feedback we get from that, decide what we do. But I think it's important that we go in at times that they're not expecting us to show up.
Thank you very much. And one final question from me. How are you capturing the voices of the residents? How do you engage them and how do you capture their feedback and levels of satisfaction?
So the care homes contractually at least are required to do feedback forms on at least once a year for every resident. We capture that, and on the whole, the feedback is really, really good. Apart from that, there's also resident groups that meet on a much more regular basis, some monthly, some 6 weekly. They often talk about access to appropriate nutrition. So food is very important, and there's lots of work going with chefs and residents to make sure that the food is culturally appropriate, tasty, you know, all the things that we would normally expect. And in some care homes, there's work with private businesses and so with L'Oreal, for example, and with the theatre, at request from the residents to have that entertainment and the activities. So if for example, a resident wants a particular activity that will always be considered, may not always be happening for a variety of reasons, but the feedback mechanisms are absolutely there. We as a department, commission, don't necessarily get too involved with that. But we certainly know that the voice of the resident at every care home is being heard.
Just to add to that, I think to some degree we do a lot of widget counting, and therefore one of the things we have spoke about and we need to do is amend the agenda that we use for the contract monitoring meetings with providers, so that it leans more towards, you said we did, for example. It leans more towards case studies that we play a part in deciding which ones they are as well. So there's a lot more of a focus on what's the real impact and quality that our residents are receiving in the homes. We know the homes do annual surveys at least of relatives and residents as well. But it's just bringing that more to the fore and less widget counting. I think that's something I think we do need to do.
Thank you very much. You can throw up, sir.
I was just wondering if you could speak a little about the residents who choose to move out of borough and what responsibility like the council, if any, continues to have after that, and what kind of how you support that transition, I guess.
Thank you very much. There are a number of reasons, as I said, why people want to move outside of the borough. It does mean that our kind of quality control is a bit less because we're not responsible for those care homes, and that's I think it's a fair point to make. The due diligence is very much around working with the host authority. For example, if someone wants to go to Ealing, we often ring the commissioner and the quality people in Ealing to say, you know, is this all right? Are there any issues? We work with the family of the people to make sure that you know that placing is as smooth as possible, and of course on an annual basis the care package is reviewed by our social work colleagues to make sure that the needs are being met. At the same time, particularly if they go into the care home there is an expectation that due diligence again is being performed by our social workers to make sure that the care home is still appropriate for that particular person.
Thank you. Catherine.
Thank you, Chair. Just to add to that, when somebody moves to a care home that's outside the borough, we retain care responsibility for them, even though they're out of the borough, which is why we have the arrangements that Johan described. But the care home is the responsibility of the borough in which it's placed. But what that means is if there are issues that arise in that care home, for example, if there's a safeguarding incident or concerns of any kind, then the borough in which that home is based will notify us, because they will find out who has placed those people there, which local authorities they've come from. So there is that connection as well. There are other safeguards and checks, and obviously all the homes are reviewed and inspected by CQC. So again, if there's a change there, we'll be notified of that and we'll be able to follow that up with a review.
Thank you very much. If there are no further questions or comments, well, thank you for this report. This is a very welcome report. As I said before, I really welcome that focus on quality and quality assurance, making sure that you're also checking and also thinking of innovative ways of doing those quality checks as well. How also residents are at the center of the caregiving process, and they've got that choice. And how you're engaging as well with them to make sure that their feedback is taken into account and that their voices are heard. So thank you so much. Great. Okay, let's move on to the next agenda item. We've got the Health and Wellbeing Strategy 2024-2029.
Thanks, Councillor Perez. So this is an item for noting, which has gone to the Health and Wellbeing Board and been signed off. So just to recap, having a health and wellbeing strategy is a statutory duty of the Director of Public Health. And this is a refreshed strategy, which will be from 2024 to 2029. We did extensive engagement with residents, with voluntary and community sector groups, NHS colleagues and others. And through that co-production method came up with priorities that people told us were important to them. So on page 50, you can see the 4 priorities. They are wide-ranging, so building on what Caroline Farrar mentioned about our borough, they mentioned important things for them were green spaces, jobs, and decent housing. They mentioned the importance of the voluntary and community sector, and also ensuring that people could stay healthy for longer. And priority 4, probably relevant to the immunization conversation, about eliminating misinformation and disinformation. So happy to take any questions about it. And thank you very much.
Thank you very much, Dr. Lang. Other questions, comments? Yeah. Please don't worry.
Is that what I'm
Yes, of
really
course.
sorry?
No problem at all.
She will tell you I've never.
No problem at all. No problem at all. Hope you feel better.
And I work in a GP, if that person forgot. I'm so sorry. I just don't want to send back. I'm really sorry.
No problem. No problem at all. I hope you get better soon.
Thank you so much. Thank you.
Okay, are there any comments on this agenda item?
It's just a small comment, and I think we'll agree. It really is dismal to read about the life expectancy discrepancy between those who are wealthy and those who are poorer, and the fact that this is widening. And this did not start with COVID, as Michael Marmot pointed out. It's a trend which pre-existed, and COVID just made it more stark, but it's getting worse. And I don't think any of us can be happy about that. I think it's quite important to say that's not a fact of nature, it's a fact of social choice.
Thank you, Jim. Do you?
Yes, and I think the work that we can do together, as you mentioned, people always say 20% of people's health is due to health services. It's 80% is what we do in terms of the environment, jobs, housing, where people live. So that's the challenge for public health. And it's a challenge, but one we still need to maintain positivity because there's good things going on in the borough, but we've just got to really work hard.
Chair.
I just wondered where the 3,000 affordable housing was going to be based in the borough.
Sorry, I'm not able to answer that one, but that would be housing and regeneration. Can get back to you if you like.
Councillor Harris.
Just as a follow-up, because that's actually quite an interesting question. Is it possible that when somebody finds out about it, they can actually put in the minutes? About the affordable housing?
Yes, of course.
It's a good question.
Absolutely. I mean, we can take this as an action and then we can circulate information once we get it from the relevant department. Absolutely.
Yes,
Jackie.
yeah, I was just going to say we could ask the Director of Housing to give us that information, then circulate it via David to
Okay, so we've got that as an action. Thank you very much. Further questions, comments? Thank you so much. So we note the paper and the Health and Wellbeing Strategy 2024-2029. Thank you very much. Great. And we also have that follow-up action, which we'll email afterwards. Once you've got that information, please. Okay, agenda item number 9, please. Health and Adult Social Care Work Program 2024-2025. Are you in agreement, Jim?
This is a remarkably long list, and it's all the items are good. There are no two ways about it, and we haven't got much time. But I would suggest 2 items need to be looked at. One is changes in GP services, because there's quite a detailed consultation going on at the moment, which will go on for several more weeks, with then results being analysed. And I think it's quite important that we look at any kind of changes which might be brought forward, because the GPs are the cornerstone, to use a cliche, but it's a fact, of the NHS. The second one is mental health. I think we actually need to have the mental health people back again. At the most recent ICB meeting, which is only a few weeks ago, the Director of Mental Health yet again did not turn up and was reprimanded in public by, of all people, Penny Dash for not turning up. But all kinds of difficulties came up about staffing, lack of beds, the amount of time people spend at police cells. I could make a long list. This came from the papers, not from me. So I think it's quite important we scrutinise what's happening with our local mental health board, and to get a report of the central London one as well, because people with mental health difficulties often travel in and out of boroughs.
Thank you so much, Jim. Absolutely. Let's put it down in the work program.
Can I mean, I second that. And autism, mental health, young children and young people transitioning from child to adult services. So all of that. And that all follows on from the little pictures we were looking at earlier.
Thank you. We know that as well in the work program. Councillor Lloyd Harris.
Okay, thank you. My understanding is this list is potentially what could be discussed, or we're expecting at some stage. So previously what we would do is we'd look through all of these and say, okay, at our next PAC, we would like, or the one after, whatever it might be, we would like these 3 items brought forward and those discussed. So these are all important, but we can't obviously, this is like, a year, 2 years worth of work. So should we not just be bunching together, I know it's an awful word, of what actually does make some sort of connection? The mental health ones, the second and the third, because we do have a problem with mental health, huge problem. So those 2 potentially, or even the 3, would go together. So that could be something that is brought forward.
I actually think this is the wrong list. I don't know where this list has come from because it's not the one that's been at CPAC or my CMB.
Alex, can't hear. Sorry.
That's fine. It's just for the chair. I'm not sure that this is the list that we were working from because there's a whole load of statutory items that have got to come through various boards. So can we just take that back and make sure we've got the right list and resend?
I understand that this is the committee's list from the work that was carried out at the beginning of from the areas that were identified at the beginning of the year, but yes, happy to follow your suggestion.
Okay, because all the joint work stream ones are ones that I know some other PACs are working on already or not.
Okay.
Yeah, sorry for the confusion, but I think that maybe would make sense because I know there'll be additional statutory ones that we'll have to look at that I don't think are on this list. There certainly are in children's. So I think that,
Sorry,
yes.
this list is suggestions that the committee's made over.
The last year, the year before. But if we can maybe bring some of those agenda items together into one item, is that, I mean, maybe that's a solution. Can I suggest as well that maybe we have a revised, work program, and then we circulate it by email? And people can comment on it. Are you all happy with that? We'll also give time as well to look at more strategic side of things and the statutory items that need to come to committee. Great. Okay. Thank you very much. Yes, Caroline.
I suppose I was just going to make a suggestion that it might be, I think Councillor Lloyd Harris may have been right in thinking that if we do sort of more contained items in greater detail, get more out of them rather than bunching if you, unless they are items that are closely related, because you can go into a great deal of depth in some of them, I suppose.
Well, I think you can produce the report because they obviously have to be produced for other panels, committees, whatever it might be. But what historically was done is that you would select 2 or 3 for whatever it might be. Now, some of these are just natural sort of fits. So if something could be that is, we're not asking to reinvent the wheel. If these are all there, then maybe that's something we could do. And I think we've had some good suggestions tonight of what some of the ones that might naturally fit together.
Thank you for your suggestions, and these are noted. Okay, thank you so much. I want to thank everybody that has joined us this evening and all the speakers, and also thank everybody attending or watching remotely. So thank you. And I think this is the last meeting of the year, isn't it? So
Merry Christmas, everyone.
yes, happy. Wishing you all the best for 2025.